And then there will definitely be some time for discussion at the end of the presentation, but feel free to enter any questions or comments you may have in the chat at the bottom of your screen, and we'll try to get to them as best we can at the end of the day, end of the talk. So welcome back to the University of Michigan Concussion Center Speaker Series. My name is Steve Berolio, and I have the distinct pleasure of serving as the director of the University of Michigan Concussion Center. And I'm excited to introduce you to our presentation today. Over the years, I've been quite fortunate to know and have worked with some of the best and the world's leading researchers, clinicians, and concussion advocates. And the goal of the speaker series is to bring those people to you, to create a space where you can hear from them and learn from them and challenge what we know about concussions and how we implement clinical care in our daily lives. I'd like to give a warm welcome and a special thanks to our guest speaker today, Kent Werner, who I'm extremely fortunate to introduce. Dr. Werner is the Vice Chair for Research in the Department of Neurology at the Uniformed Services University. He is a neurologist, neuroscientist, serving as an active duty commander in the Navy Medical Corps. He's also an associate professor and Vice Chair for Research in the Department of Neurology at USU. Upon entering the medical corps, he completed his medical degree, cellular and molecular neuroscience doctorate, and neurology residency at Johns Hopkins University. He's board certified in sleep medicine and neurology, treating patients with sleep and TBI-related neurological disorders at Walter Reed Medical Center and the National Intrepid Center for Excellence. His research interests include sleep and the glymphatic system, modulation, related molecular and electrophysiological biomarkers, TBI and its impact on sleep-related biology, and novel therapeutic approaches. Today, we'll be talking about the short and long-term impacts of TBI and PTSD on sleep physiology and cover current and novel approaches to management. Please join me in welcoming Dr. Werner.
Hi, everyone. Thanks so much for the kind introduction and really for the wonderful experience of visiting this institution. Congratulations on what you've established here. I was super impressed, and I had a lot of fun already. So more fun. Hopefully will be some challenging questions. You guys can call me out in the middle of the talk. It's fine with me. But what I'm going to be talking about is understanding sleep physiology, just a real quick run through, and TBI physiology, and then an understanding of where we are on TBI impacts, and then talk about different approaches for biomarkers and therapeutic approaches. So starting off with sleep, I think this painting is beautiful. It nicely depicts most societies' views on sleep up until about the last pandemic 100 years ago as essentially a near-death state. In fact, the god of sleep, Somnos, is laying next to his brother, Mors, the god of death. He's not looking so hot. And so you get the idea that sleep is just the brain, the body shut down, nothing more to it. And that was changed with the last pandemic when cases of people essentially sleeping themselves to death would show up, and this was in the era of the Spanish flu. And what these people did was, in some cases, just sleep 20, 30 hours a day until eventually they passed, whereas other cases actually would be perpetually insomniacs, and they too would die. And when the brave neurologist, this is classic garb for a neurologist, I'll mention, we're very adventurous. Bonacanimo decided to take these unfortunate patients that he lost to the autopsy suite and look carefully at their brains. And he did identify correlating brain lesions that would line up with insomnia compared to, say, people who were perpetually hypersomnia. And so he proposed that indeed sleep might be regulated by neuronal circuitry, and in fact, in these regions of the brainstem. And it was pretty controversial, not very well received at the time, but it did spur on, over the next 50 years, more and more experimentation, lesioning experiments in cats and rodents to pull, that's a rodent brain you're looking at, to pull apart what's going on when we just take a little piece of it out and boom, we lose wakefulness, for example. And one of the big breakthroughs was Maruzzi and Magoon's discovery of the reticular activating system, which is in the back of the brainstem, where we make in the locus coeruleus. You've got your acetylcholine made in the basal forebrain, which is distributed all throughout the brain. Your locus produces the noradrenaline or norepinephrine all throughout the brain. Histamine and your dopamine and serotonin, these are all the monoamines that contribute and have projections to supply the brain with these wakefulness molecules. Now, I think they're worth mentioning, not to give you guys a neuroscience lecture, but because we modulate each of these molecules with our pharmacopoeia, and they can have impacts on sleep. They're interesting because what they do, similar to acetylcholine, is they lower the threshold for firing. So these circuits, now instead of the normal default sleeping, if you cut a piece of cortex and you just put it in a dish, it will electrophysiologically look like it's sleeping. It's kind of our default. But if you lower the firing threshold and you add some of these key neurotransmitters, kind of in a non-exact method, like these aren't synapses like you see in diagrams, one neuron talking to another. This is more like a garden hose with holes poked in it, showering norepinephrine and serotonin to generally raise the activity of the brain. And so that might be why we don't have problems when we use SSRIs. We're kind of boosting something non-specifically, and that's okay. But there's more to the story. There is the orexin molecule, and if you have a lesion in your brain because of autoimmunity, more common in women than men, you'll lose your orexin neurons and you will have narcolepsy. So orexin is important for stabilizing the on state of these wakefulness molecules. And there's evidence in TBI that perhaps orexin is an important molecule to track, that it does go down after headache. And then there are circuits dedicated to the symphony of sleep. Now, I say symphony because any piece of cortex, when it's had its fill, is just going to start sleeping. That's not very optimal for survival, right? You don't want pieces of your brain awake while others are asleep. In fact, that has been shown to occur with chronic sleep restriction. And we're studying that in our lab, but that local sleep phenomenon is what we're trying to avoid, so we can have everything on at the same time and be, high performers, high survivors. And so to master that, coordinate that effort like a symphony, the VLPO, ventrolateral preoptic nucleus, is really one of the master switches. And the longer you stay awake, the more adenosine accumulates, and there are other molecules known to trigger VLPO activity. And what this does is send powerful GABAergic blockers to each of these wakefulness nuclei to allow the overall firing to simmer down, and all at once they say, we're going to go to sleep together, right? And when that is satiated, or when you have your adenosine accumulated, it sort of pushes you into sleep mode. And we call this a flip-flop switch. This was coined by the great neurologist, of course I would drop his name, Cliff Saper at Beth Israel, who showed that these circuits prevent simultaneous wake and sleep flip-flopping. So you have a switch. And so the GABA projections block your wakefulness, allow you to just satiate the sleep need. And of course, we can enhance that with drugs. You can increase the GABA activity with, for example, benzodiazepines or BZRAs like Lunesta or Ambien. And then you can also block the wakefulness molecules with common sedating drugs like Benadryl, hydralazine, a similar molecule, amitriptyline, doxepin, so your TCAs. These things all can block histamine. Our most potent histamine blocker actually is doxepin. It has nice long-lasting effects. And then you might even go after dopamine with things like antipsychotics, like quetiapine. You can see that as a sleep intervention. So these are some ways to manipulate the system. And then latest on the block are the orexin antagonists. We have 3 or 4 different orexin blockers that you can use to treat insomnia. They actually seem like they might be quite promising in TBI and PTSD. And then the switch can go the other direction. Once you've fulfilled your sleep need and these nuclei become active, they have their own reciprocal inhibition, to block the sleep molecule or the sleep nuclei from kicking on. So it forces you to either be awake or to be asleep in a functional switch. Now that can be modulated by taking drugs that boost your monoamines, like the SNRIs, SSRIs, amphetamines, modafinil, dopamine agonists. But stress itself can press that button and overtap our endogenous use of these molecules. So why then we go through all this trouble of sleeping? What about it is non-negotiable? If you have a brain, why must you sleep? So does anyone in the audience have any knowledge about functions of sleep that you might have heard of? Things that happen that are important? Yes.
So I've certainly heard of protein clearance during sleep.
Yes, it's the newest and hottest thing discovered 10 years ago, waste clearance. Good, any others?
Memory consolidation.
Memory consolidation, hugely important with sleep. Yeah, but you can see it in real time when it happens, the EEG.
Stopped you from being grumpy the next day?
Yeah.
I don't work in this area.
Mood regulation, actually, the REM sleep particularly. Yeah, very good. So there are a number of things. Kind of maybe the lowest hanging fruit is the physical recovery. Okay, my body feels better. Well, that's largely quarterbacked by growth hormone release, which is driven during your deep stage of sleep, right? And that's your chance for the fight or flight system to take a rest. It's on all day long. At night, it has to go down. And in fact, during REM, it's essential that it's silent. But if you have TBI, PTSD, that might be different. We'll talk about that. Memory consolidation, we covered that. Immune regulation. So if I go and shake your hand and you wiped your nose from your cold, if I had less than 7 hours, I'm 3 times more likely to catch that cold. So the immune consolidation of sleep is crucial, not just for protecting your defenses, but also for a good response to your vaccines. And then synaptic downscaling is partly related to waste clearance. These are things we need to do to maintain the brain. So it's no wonder we spend a third of our lives doing it. It's a lot of important work. It cannot be done while you're awake. If we could have gotten rid of it, we would have, right? It's a vulnerable state. However, even though we need about 8 hours, 7 to 9 is the healthy range. 2/3, these are 2 different military studies. 2/3 of the military gets 6 or less, compared to the civilians, where 2/3 get 7. And in the short term, that's like being drunk. That's been shown, and not a shocker, we do silly things like fall asleep while driving. And the consequences, if you're driving something big, like in my profession, not a small thing, right? So this is the same kind of ship I served on, a DDG, a destroyer. And I was terrified when I heard that we lost 7 sailors in June of 2017. And 2 months later, we had another crash, 10 more sailors dead. And if you look at the investigation, it's not like a part of the ship broke. No. Look how many sleep hours the crew had at the night of the crash. So it's not a machine, it's a system problem. We don't give our people the sleep that they require. And the short-term consequences are disastrous. But the long-term consequences aren't so great either. There are a number of studies linking long-term sleep disruption with, for example, dementia. Maybe the failure to clear these dementia-like molecules, which are a normal byproduct of everyday thinking, like amyloid, right? This is a study from Christine Yaffe's group, where you can see in the box, she took people in their 70s that were healthy, knowing that give them 5 years, we're gonna have plenty of dementia. And that's true. 1/3 of 85-year-olds have dementia, have Alzheimer's. And so she said, let's see how they do in 5 years. Some people will use their CPAP, some people will not, but they all have sleep apnea, right? And you can see there's a 70% increased risk in the people who do not manage their sleep apnea. Good news is, hey, 5 years made a difference in 70-year-olds. So it's never too late to get in there and fix your sleep. We see this in longitudinal studies. This is a 30-year cohort. where they took 4,000 people, all of them, 111 of them ended up getting dementia. And then they controlled for all the things you'd worry about, as shown on the slide here. And all they did was measure their sleep with a watch for 9 days while they're in their 30s, 40s. And then 30 years later, see what happens. And you can see that there's this U-shaped curve where the people sleeping less than 7 hours develop increasing risk for dementia, but also the people sleeping greater than 9 hours end up developing a pretty significant increase. So does that mean sleep's bad for you if you have too much? Now, if you look at these people who are sleeping 9 or 10 hours, their sleep's so bad because they're not treating their sleep apnea, which, you know, in the elderly population is far more common than 10%, right? People laugh at grandpa snoring. You know, it's not that funny if he's got dementia 5 years later, because you got to take care of that. So we do need to treat it more than just something, you know, that looks or sounds silly. It has significant impacts. And you could even do this. This is a really beautiful study from one of my mentors at Hopkins, Adam Spear. He took a bunch of healthy 50 to 70 somethings, no dementia. And he said, hey, how many hours a night do you sleep? And then he looked at the amount of plaque, the Alzheimer's plaque you can measure with the Pittsburgh B compound. As a Pittsburgher, I like to brag on the name. And what he showed is that if you're sleeping 6 hours or less, you have a lot of plaque in your brain compared to the people who are sleeping 6 to 7, and they even have more compared to the people sleeping greater than 7. So indeed, the link between amount of sleep and dementia is not surprising. And what is one possible mechanism? 10 years ago, this lymphatic waste clearance story. You can see here, this is a mouse actually not anesthetized. Nerve block, and then been trained to sleep. And every time the mouse would drift off into sleep, they would capture it and inject the green dye. And you can see that when the green dye is going in, there is loads of movement, lots of space to move around in this brain window of a live rodent sleeping. But when the rodent's awake, they inject the same dye with a different color, and it barely moves around. So during wakefulness, they saw no movement, and they claimed, hey, during sleep, our brain opens up these passageways to clear waste. And then, finally, just a few years ago, it was shown in humans. Now, you can't get away with measuring this in any other country but Norway and China. But if you do inject into the spinal fluid gadolinium and follow it over time, you can see that it makes its way into the brain tissues with higher and higher concentrations. And what they showed was that if you sleep deprive these people, it reduces the entrance into the brain. So this concept of movement of CSF from the subarachnoid space of the brain through these water channels that are aquaporin 4. Look how they're just like wallpaper, painting these deep end processes of the astrocytes. And then that water passes through by night while you're sleeping and carries the waste out. And so Christine Yaffe and others have proposed, hey, sleep is an important linker to dementia. And when you don't sleep, you reduce your clearance, you get increased inflammation, you get neurodegeneration triggers, hypoxia can take place, especially if you've got apnea. And so these factors plus genetics create a model that I think is pretty plausible because you can recreate it in animals. It's pretty nice. And we see it in humans. All right, so then we switch gears. We talk about TBI, which is probably not so new for you folks. We know it's important. We know most of it's mild and a lot of young males. And we know that it costs a lot, right? Because people keep living with these burdens despite having had the injury years ago. And what are the hallmark symptoms? You guys know this well. Poor sleep and fatigue quite common with cognition and mood, headaches and vestibular. And so this has been examined in the mild population in the military by a number of people, but I like Christine McDonald's longitudinal 5-year study because she went there in the field and said, hey, I'm going to take a bunch of people who got blast concussion and compare them to your own sort of classmates in the deployment that have the same exposures minus the concussion. right? And see how you do over 5 years. So they have the same deployment, and very clearly the ones who get the blast concussion have more PTSD 5 years later, depression, anxiety, and of course, insomnia. Now, a lot of folks will say, well, you know, their insomnia is driven by their PTSD. If you just take care of their anxiety and their PTSD, they'll sleep just fine. And that may be an important component, but there's a lot of evidence accumulating that it's really bidirectional. Not to mention they have increased sleep apnea, which you can treat the anxiety all you want, but that won't prevent them from choking themselves hundreds of times a night. So one way to look at that, because it is hard to separate PTSD symptoms from TBI in a small population like that. There's multicollinearity in your models, but if you look at a large 200,000 veteran population like Dr. Lang did at UCSF, she followed them for 15 years through their records and found that after the incident of the TBI, if you adjust for all of the PTSD and comorbidities related to psychiatric disorders, medical disorders, demographics, you still have a good 40% of that model explained by the TBI for increased sleep disorders of every type. And if you look in the blood of the TBI patients, you do see elevations, even 5 years after the injury, of some of these neurodegenerative proteins like amyloid and tau. You can sample brain tissue from the blood, in theory, by enriching for brain exosomes in the blood, and by doing so you get a little more window of differences across that are specific to the brain across TBI versus no TBI. Neurofilament light's another neurodegenerative biomarker. And of course, if you do large studies, and many of them have been done, you see there's a link to multiple concussions and dementia. What really bugs me is that these large studies, which conclusively show that lots of TBI can lead to dementia years later, none of them really looked at sleep. Because the sleep is so bad in TBI, that could be like the major modifying factor. Not only that, it's not just be a mediator, but a target for therapy to prevent. So that's really what got me fired up and what driven the things that we're doing in the lab. And one target right there could be just the glymphatic activity, and that's been shown in animals, and some suggestive evidence in humans that after a TBI, you look at the flow of the dye through the brain as a readout for glymphatic activity, that on the ipsilateral or the side of the injury, it goes down and it gets worse by day 7. Maybe increased inflammation, swelling. But then the other side becomes bad, where there's no injury whatsoever. Why does that go down too? So it may not just be a structural thing, it's a signaling thing. And one thing that they showed in the original science paper of sleep clearing waste is that if they inject that animal with blockers of the fight or flight system, right, blockers of the sympathetic alpha signal or the beta signal, that enhances the glymphatic significantly. So I do think that that's probably what's happening here, because there was another Nature paper that just came out within the last year, and I didn't show the slide, where they did this TBI on rodents and then gave them beta blockers and alpha blockers as a cocktail, and they restored their glymphatic activity. All right, so what is the model that I'm proposing is that you get your injury, you get inflammation and disruption of the circuits themselves. Those things together will disrupt your sleep. And then you have disrupted physiological processes we've been talking about. And each of these things can further bring you towards a phenotype like anxiety or headache, pain, PTSD, even dementia. And those things, of course, as they progress further, perpetuate inflammation, sleep disruption, and so you kind of have a nasty feed-forward cycle. Where what if we could just go ahead and target that sleep-wake disorder and possibly break it? One way that I asked the question in a sort of weak first step as a new PI was to say, hey, couldn't we take a look at these TBI patients and separate them by good sleepers and bad sleepers? So in the military, if you're Pittsburgh, there's my city again, Pittsburgh Sleep Quality Index score is greater than 10, you're a bad sleeper. And what we see is that the bad sleepers in the TBI population clearly have elevations in their blood levels 5 years after injury, 5 to 9 years of neurofilament light. So it's still sticking around. Why is it still there? Now, it's cross-sectional. I can't prove any causality about the sleep. Maybe the inflammation's worse, and that makes the sleep worse. And we see the same thing in inflammatory factors here. And that includes measurements from exosomes, which gave us better correlations. And so I think that those biomarkers are just the first step. And I think if we work on the clinical problem more carefully, we can ask a way to integrate the biomarkers and make impact in the field. And so I want to talk a little bit about how we see these patients in the clinic. And if someone has a TBI sleep-wake disorder, is that any different than someone who just has a sleep-wake disorder? I would argue perhaps not yet, because we haven't done the work to identify TBI-specific therapies, but there are some hints that indeed it is different. And we'll talk about those. But the first thing is when you see someone with a concussion, you have to have a much higher suspicion for sleep dysfunction. They're not going to complain. In fact, in our TBI clinic, we just take all these TBI patients, they're complaining about their TBI, variety of complaints. Yes, sleep can be on the list, but it's not often a priority. And we give all of them a sleep study, which is just a snapshot of one night, not perfect. But what it's really good at finding is sleep apnea. And these are young, fit, special operators for the most part, right? They don't even complain of snoring, most of them. Or their wives might say, yeah, sometimes when you had too much to drink. Half of them have sleep apnea with our screening. So it's something that can really swing by you under the radar. You totally missed it. And that's the message here, is you need to be vigilant about sleep disorders. And it's not just apnea, it's circadian dysfunction, which as far as they're concerned, their sleep quality just sucks. They might say I have insomnia, right? But they have dysautonomia that can be a good correlate of poor sleep. PTSD, depression symptoms, those correlate. Headaches, neck and back pain, even their vestibular symptoms have been shown to correlate with their poor sleep. So they're tightly related, and we probably need to be aiming at both targets at the same time. Now, the inflammatory markers do correlate too, but we don't treat chronic inflammation in a TBI patient, right? We don't know how to do that, but it's something to consider as we go forward in the field. And same with their deficiencies, low orexin, low melatonin. We're going to talk about some of that. So there are guidelines for managing sleep in the TBI population. I was really fortunate to be part of this group, and we put out the most recent recommendation in 2020. There's a minor, I would say, update in just a year ago, but what I think this can be useful for people who are in the primary care setting. So I want to talk about a case. So we've got a TBI sleep neurology clinic where I see patients, and in walks a 23-year-old special operator with multiple TBIs. And he's got headaches, dizziness, insomnia, short fuse, brain fog. He's punched his wife in bed. He's violent enactment of dreams. And so we need to break down, boy, this guy's got a lot going on. Where are we going to start? Well, we do hear frequent awakenings in the middle of the night, early awakenings, so that's insomnia. So at least there's some component of what's going on. How do we manage insomnia with TBI? And still, cognitive behavioral therapy for insomnia is the first line. We just recently published this clinical trial in TBI population, asking them to, since it's hard to find providers, sometimes asking them to engage with an online app to treat themselves with an algorithm. And indeed, like other online studies before it shows that it works. But look at the dropout. We started with 82 in the treatment group because we ratioed 1:3. And by the end of the study, we only had 25 left. I mean, it is hard for people to stay involved with CBTI. And so while it is a wonderful resource, I don't think it's enough. We're not serving our population with just this answer. There are a lot of other approaches though, and they've had success. So light therapy, there are current studies underway. Here's one of the published ones where they took people with mild to severe TBI, but also stroke. And it's a crossover. So while they're giving them this light therapy in the morning to kind of reset their rhythms, their insomnia scores go down, which is great. And then when they cross over, it comes back up. Melatonin. Although the AA, the American Association of Sleep Medicine, doesn't recommend melatonin for insomnia, right? But in the TBI population, there are now 8 studies that show pretty good response to melatonin. Now, half the melatonin brands in the US could possibly have 0 melatonin in them. So you want to buy a brand that is sourced from a pharmaceutical grade, that has third-party testing. That's just a side note clinically. But indeed, a half a milligram shortly after, maybe an hour after dinner, can be quite effective. And if you look carefully at people with insomnia, about a third of them in this small study were shown to actually have circadian rhythm disorders that people were just not treating. So you can CBTI till the cows come home. You're not going to treat circadian disruption. And why might that be? Well, many of them are delayed, but some of them are just purely irregular. And it could be that the amplitude of their signal is not good enough. And this is a measurement of moderate to severes, but you can see that the controls have a much nicer spike in their melatonin as the sun sets compared to the TBI patients. Larger studies are needed. We don't really know the story in the concussion population at large. So how else can we manage insomnia? Well, with a chronic pain, gabapentin can be a good home run. It does enhance slow waves, but it's also a cause of sleep apnea that most docs do not know about for some reason. So if you put them on gabapentin, make sure you didn't just give them sleep apnea, and if you did, make sure they're treating it. Doxepin is great for maintenance. It's our most potent histamine blocker, not addictive. I do try to use it as a bridge, so weeks to months rather than years. Suvorexant is one of the multiple orexin blockers that are available now, and there's some animal data supporting it. We don't have the data for these, but the environment modulation seems to be anecdotally very helpful for some. Could be 20 pounds of a blanket, or it could be a swaddle effect. Bed cooling devices are a big deal because 65 degrees is what we recommend, and many spouses don't like 65 and it just ain't happening. So if you don't want a bed divorce or a bedroom divorce, which is actually a common successful therapy, you can cool your side of the bed. That needs to be studied though. We don't have great data to support it, but it's just anecdotally popular. So what else do we learn about this case? There's signs of sympathetic activity, tachycardia, sweating, racing thoughts. And he says his Whoop is reporting that his sleep is very poor. And says my HRV is terrible, doc. Well, while I don't like to overinterpret these devices, HRV is actually a fairly accurate measure. Now, how to interpret it is another thing. I think the norms need to be figured out, one of the projects in our lab. But if you just look at these particular components, they are signals of sympathetic hyperactivity. Just beware that devices can also cause orthosomnia, right? Obsession with your sleep, and whatever the numbers tell you, you're so anxious, your sleep's even worse. So these should be looked at maybe once a week or once a month. Don't look at your numbers every day. But yes, my patient was onto something because plenty of studies are showing elevations in signals about the autonomic function, specifically decreased parasympathetic and increased sympathetic activity. Is that any different from PTSD? They have that too. I have no idea. We may never figure that out. However, athletes that don't have PTSD but do have concussions, if we study them more diligently with their parasympathetic, sympathetic measurements, and then compare that to the folks with PTSD, we might get somewhere. Those studies are missing, surprisingly. We've had the tools for decades. One way we address this in the PTSD population, you might have seen published studies where we inject the sympathetic ganglion with lidocaine-like blockers. And that block maybe only lasts a few hours to a day or so, but the effects seem to persist for weeks, where people feel more chill, less fight or flight, less anxious, and they do say they sleep better. The pill version of that is an alpha blocker, penetrates the brain quite nicely, prazosin, often used for nightmare disorder. And so what I'm proposing is that maybe this is sort of a spectrum that if a little bit of that too much activity, you might just have insomnia where your switches aren't working right. But you get too much, your nightmare circuits can kick in. And then you get even more, your paralysis circuits go away. So you need to be paralyzed during REM, right? Because the brain's doing all this awake stuff, crazy dreams. How are you going to enact your dreams? You don't want to do that. So the body turns on a paralysis circuit. Now, if you have narcolepsy, accidentally, that circuit can kick in when you get excited and then you collapse. It's called cataplexy. But normally that circuitry should be on during sleep. But if you've got fight or flight hyperactivity, there are circuits that will crosstalk and block it. And so dream enactment could be a version of traumatic sleep disorder. So there are a lot of ways you could potentially address it. All of these are really just kind of suggestions. I think clinical trials are desperately needed to look at ways to modulate sympathetic activity. But before we can do that, we have to know what's a normal amount. How do you even measure it? We do all these prazosin or prazosin trials without measuring their sympathetic activity. It's like giving insulin without measuring their glucose, right? So the field has to catch up with itself a little bit. So back to the case, these are the meds he's on. I have to admit, methylphenidate, extended release, may be a problem. It's only 10 milligrams and it's in the morning. But that can boost all those wakefulness molecules and essentially turn off REM sleep completely if it gets too high. Same with venlafaxine. Although that can help mood quite a bit, especially if you take it at night. A lot of those patients have 0 REM. Gabapentin, that could balance the scales, maybe sleeping better with the gabapentin. So we do a wrist actigraphy. We find his bedtimes are too early and wake times are too early, sorry. Not enough time in bed, so he's already short slept. And his sleep study shows that he's got sleep apnea. So 10 times per hour, he is limiting his breathing. Now the oxygen doesn't go down so much. That's kind of a standard thing with the TBI folks. It's like their brain wakes up, so that gives them a score. But their oxygen, they're so healthy, I think their pulmonary reserve is taking care of the oxygen part. Again, making them easy to miss if you just stick a PPG on their finger, look how they do. So it's about the arousals. So this low arousal threshold is possibly an issue. Look at 57 arousals per hour. Not much deep sleep going on for this poor patient either. You should have about 20%. So with that OSA, this is a whole other problem we got to manage at the same time for this patient. And so as I said, 50% of our patients have sleep apnea. Still the #1 way to go is CPAP. There are of course other ways, and a lot of docs forget about the old oral appliance, an upper and a lower, fits in your pocket. So I think it's important to know that you don't have to use a CPAP per se in some cases or many cases. But what about this low arousal threshold? What if I didn't mess with their airway at all? What if I just made it harder for them to wake up and maybe they'd sleep through their little airway closures and be fine? Well, so far we don't have data that works, and I wouldn't recommend any of these choices just yet, except for perhaps prazosin, the alpha block. I wonder, you quieted down their alpha, could you manage their sleep apnea? All right, so actigraphy, polysomnogram. We also want to tell you about a sleep study though. He also had normal amount of REM. I was just telling you how these drugs can abolish REM, and he had 20% as the normal sleep scorer sees it. If you look more carefully at the REM, there was not normal REM. And a lot of labs ignore it. They don't even bother to look at it because it takes time, it takes extra expertise. And so these are things that we're just blatantly missing widely in the sleep field. The average heart rate was way higher than it should. And here's another, thanks to the Whoop, we know his daytime heart rate 62. Why is his sleeping heart rate 82? Again, these are probably evidence of fight or flight hyperactivity, destroying the REM, giving him muscle tone during, here's a night of REM, so the muscle tone should not be here. It should be nice and flat paralysis. And in fact, if you look at this loss of atonia, this loss of paralysis, Miranda Lim's group showed that it's elevated in the PTSD and the TBI population. And when you combine them, it's even more so. We're doing a similar study. She got it out before us. And that's good because we're seeing similar things. 2 papers are always better than 1. And so this idea that there's maybe, sure, they enact their dreams. And in the sleep world, that's called REM behavior disorder, often referred to as idiopathic REM or IRBD, if you don't know what caused it. They're not on drugs and they don't have PTSD, I would say, is another criteria they should add. And yeah, you can treat it with melatonin and clonazepam. But, traumatic sleep disorder could be something different. Maybe it's more of an autonomic activity issue. They lose their atonia. And could we treat it with an alpha blocker? And in fact, we do see clinically great results with alpha blockers. So the clinical scenario I wanted to present to you, as I wrap up, I'm going to talk a little bit about the research in the lab, but really want to save most of the time for discussion, is that what if we look at new biomarkers when we evaluate for sleep? And we're not just churning people out with apnea or insomnia or maybe often this circadian disorder. What if we use biomarkers to measure the glymphatics, measure the autonomics, measure the hemodynamics, which we ignore completely, and the electrophysiology? What if we characterize new disorders? Because how many people come out of a sleep lab being told, oh no, doc said I was fine, but my sleep still sucks? So I think these are key missing links that are low-hanging fruit that we're going after in the lab. And one way that we're aiming to do that in the SWORD lab, my team named it. I think they did a neat job. I like the acronym. You don't use a lot of swords in the Navy, but we do use some. And we're a tri-service, okay? So, we're looking at different ways to measure sleep physiology that are new. So new scanner developed by GE, fastest one in the world. People sleep in there. We're developing a headset. This is something that you can wear to track your brain water movement while you're sleeping. So maybe we can measure glymphatics without injecting in the spinal fluid, right? We're doing blood tests to see what waste the brain dumps into the blood, see if we can measure it there. And still interested in capturing with wearables and, the phone, EMA, self-report type of things. Those are critical to tie all of these together. And once we've characterized our various biomarkers, these categories, we then look to ways to modulate them. And largely we're going non-pharmacologic because it's already been shown you can modulate sleep with electricity. And now this headset has been replicated that data, and we're using it as an insomnia therapy in a clinical trial right now. And it shortens the time to fall asleep. It entrains the brain in these slow waves. We're using an Apple Watch, essentially, that will vibrate at you when your heart rate spikes in your sleep, ideally not waking you, just kind of nudging you away from your sympathetic spike. We have a study looking at focused ultrasound. So instead of using a needle and going through the skull, we can take 2 arrays, and I'll show you an example. I'll show you an example in a second, but first for the slow wave, I just want to point out that if you do if you look at the electrical signal of a brain, this is a spindle, very easy to see. And then you see a big slow wave kicking in. And both of these things are the brain consolidating memory in real time. So you need them to put your memory together. You need them to clear the waste and the release of the growth hormone. And it turns out the brain goes into the REM. So this is like a course of the night, by the way, right? So we sleep in sort of 90-minute cycles. Ideally, we get a bunch of them. Ideally 7 to 8 or 9 hours of sleep. And what you see is more and more of your REM sleeps in the morning, or the wee hours of the morning, and less of your slow wave, because that's a priority. So if you look at your REM sleep, it has its own little signatures called theta, and you can potentially enhance that. And by doing so, maybe enhance emotional processing, mood regulation, including things like cognitive flexibility have been related to REM sleep. And so one way to modulate the slow waves is with this electricity I was telling you about. So this is a night of wearing it where before the stimulation, we look at the slow waves, and then after the stimulation, we look at the slow waves. And you can see, here's the stimulation. You can't measure EEG during that period. But after it's done, man, we get all these nice big slow waves. And in fact, people's memory improves as the slow waves improve when they wake up the next morning. And actually, when I wore it, I woke up earlier, refreshed faster. So we do wonder if we can sort of nudge sleep along if you have a shortened opportunity. And this is the targeting of the nucleus. So I have two arrays on my temples, and I can target with the beam steering of ultrasound energy to activate just tiny little centimeter pieces of brain. And we're doing this project targeting the basolateral amygdala to open up the channels and make REM sleep happen more effectively. We can see increased theta frequency, but we still have to develop the study. It's just IRB approved. So I just want to state that none of this could happen without these amazing partners that we work with and this incredible team, which is ginormous. And at the helm is Elizabeth, the scientific program manager. She's here today. So how she manages 15 projects and over 15 employees, I don't know. But this team has been fantastic. I couldn't be happier and more lucky to work with these folks. So if you guys are in the area, please come check us out. If you're visiting the NIH, we're just across the street. Shoot me a text or an email, and that's all. So thank you for your attention. Happy to take questions.
Appreciate the talk. We got a couple questions online. I'll start with one of these while people are formulating their own. The first one is, what is the starting dose for melatonin and what is the top dosage that is helpful or safe? I see patients who will start at 5 milligrams and keep increasing if they do not find it effective.
Yes. So starting dose is 0.5. And if you see 5 milligrams on the bottle, you don't know for many of the brands if you're taking 0 or if you're taking 50. And that's been shown in a study. They took like 25 different brands. In Europe, it's regulated. So if you can get a regulated source, that's number one. Number two is start with 0.5, do it around an hour after the meal. You generally don't want food and melatonin in the bloodstream at the same time, if you can avoid it.
Then the second one here, have you tested UCHL1, GFAP, beta tau, tau 181 in patients that you have seen an increase in NFL?
Yes, they've all had GFAP and UCHL1. UCHL1 is pretty much dead. We don't see much of it. There are reports of chronic UCHL1 elevations in some small studies, so I don't know what to say about that. I think jury's still out. But we have a 2,200 TBI population that we haven't written up yet. And we do see GFAP also chronically elevated in these folks, along with the NFL.
I have one more, but I can also hand it over to the audience.
I'll ask a sort of related melatonin question. Do you use doxepin like acutely with concussion? Or is this more long, like people who have prolonged symptoms?
So I really don't see acute concussion that much, first of all. In the rare instance that I do, because by the time they get to me as a sleep neurologist, they've been through the ringer. But in the rare instance where I do try to avoid it. I like to see how they're doing, at least for the first 30 days, with other techniques, non-pharmacologic techniques, ideally. And it's only because I don't know what harm I'm doing. If you're blocking the histamine pathway, which is so crucial for cognitive function, it may have some untoward effects that, granted, they may not mind and maybe they're short-lived, but I don't know what knobs I'm really turning. If they get better, in 30 days they're gonna get better anyway, potentially. So now they think they're dependent on this medication that helped them so much. So,
Yeah, I think we see people who, they have both. They've got trouble getting to, some people have trouble getting to sleep, some people have trouble staying asleep.
Right.
And that's where I think the doxepin could potentially play a role, but I've never used it acutely.
So I will say my number one first line agent, which I didn't put in the talk because the data for sleep, actually there is decent data, but I need to add it to the talk actually. So magnesium is by far my favorite. It's nature's gift, right? When a pregnant woman is seizing, I can't give her seizure meds. I'm gonna hurt the baby. But I load her veins up with magnesium and quiet that hyperactivity down. It's a great nerve hyperactivity blocker, and you can't hurt yourself. You can take a whole bottle of magnesium, contrary to what the pharmacists keep yelling at me about, because I prescribe high doses.
How high?
I'll go as high as 2 grams, depending on the substance. If it's a magnesium threonate or glycinate, those are heavier molecules. You might need much more than 2 grams, but that data is not great. I think those are possibly better the problem with magnesium is it doesn't cross the gut very well. That's why you need the high doses. But you don't want to have so much that you poop your pants. So ideally, some people don't tolerate it as well as others with the gut. So I usually start with 1 or 2 pills a night. And then every 2 weeks, I'll have them take an extra until they're taking 4, maybe 5 pills a night. And usually right after the meal, typically, because it's better absorbed food.
4 or 5 pills. And I hate to dominate the conversation, but I can't help to ask, what about L-theanine?
Yeah, so there is some data that shows L-theanine can have a sleep modulating effect. They're kind of small studies, and I don't really know what knobs I'm turning there. I'm not opposed to it. I don't see great toxic potential with L-theanine. I don't know how much I'm actually getting when I buy L-theanine. So it's kind of lower on my totem pole. But I think people underutilize mag, and so I usually hit that hard. And with TBI, I do potentially throw in some melatonin, but not till I've gone through all of their environment and they're practicing their inner ninja skills, their breathing and such.
We have another one from online. You showed a photobiomodulation bed, but did not comment further. Have you started any projects using photobiomodulation? In previous studies with MTBI or ex-football players with possible CTE, there have been improvements in sleep.
Yes, and I didn't talk about it on purpose because I wanted you to ask that question. So we did have funding for a project, and we bought the bed, and we went to great lengths to have them redesign the bed so that it could have a sham capability. And we were all ready to go, and then our funding got pulled. So we will do that study, but we have to get the funding re-upped. There are 2 papers showing that photobiomodulation may in fact help enhance sleep. The mechanism isn't clear. They did whole body. It's possible you only need to hit the skull, but we have no idea. It does increase, very nice evidence that it increases ATP production in the cells, and it readily goes through the brain, at least the infrared part does, not the red. So would red work at all? I have no idea, because a lot of these beds will throw everything at you and claim that, oh, well, if we oscillate at this frequency, this is for fertility, and we do this frequency for male calmness. I mean, it's just unbelievable what kind of things they make up with these beds. They're highly unscientific. And when we were buying beds, buyer beware. And Elizabeth led a really cool study on this, showing that while they claim to put out X amount of power, they actually, some of them put out 1/100th of that amount of power, which will do nothing with photobiomodulation, but it looks neat, and spas selling them or working with them. When we go to check out the spa and measure the light intensity and the energy, we had to break it to the owner that, hey, you were sold a lemon, it looks cool, but it's doing nothing. And then of course the company came and didn't fix it. But so beware, if you're buying these things, there's a lot of technical background that you should probably check before you implement it.
Has there been any research in regards to the inflammatory cascade response and treatment following TBI?
Yes, there are a number of papers showing, including some of the ones that I showed you, chronic elevation of inflammatory markers. One study I didn't mention was a track TBI study where I worked with a group to measure the insomnia trajectory over about a year. And we got blood on day 1. And what we saw is the elevations in CRP and the elevations in GFAP were really strong predictors of the likelihood that they'll continue to have insomnia or not 1 year later. So there's a lot of sort of correlative evidence, but how do we tackle it, and do we even target it? I don't know. I think that's an important place to look.
I have a question, and it's like a half-baked question, so I apologize. But in thinking about concussion and TBI, and like one injury is not the same injury for everyone, you have different outcomes or subjective or objective impairments. Do you consider mechanism of injury in some of these sleep assessment or outcomes, and are better, some better for others, or like are outcomes different between mechanisms that you're looking at?
That's a really good question. And in our studies that we have with the longitudinal chronic effects of neurotrauma, that's a DoD VA collaboration, that's the 2200 population I was talking about, we track whether it's blast or impact, and in most cases it's both. So it does make it hard to sort of tease it apart because they have such a multiple incident history. So I don't know what to do about that yet.
Commander Werner, it's just great to have you here. I really liked your compelling model. TBI happens, you understand sleep apnea is happening. That is preventing healing, possibly.
And inflaming it more.
And inflaming it more. You could easily be working further upstream just on sleep apnea.
Yes.
I wonder, do you just like a more complex problem? Maybe that's something you're also working on, sleep apnea period and prevention.
Yeah.
Are you in fact, it takes a lot of money to run this suite of work. Are you interested in both on their own? And might preventing sleep apnea like be protective against TBI? Maybe that's a stretch.
No, it's not a stretch. So poor sleep before an event leads to more head injuries, right? And so sleep apnea could be one of those poor sleep mechanisms. So upstream OSA management's a big deal. It's just part of the puzzle because a lot of the guys have, like these trials here are for insomnia. We do have a TBI, a sleep apnea study that we're kind of loosely collaborating with Johns Hopkins for after head injury, treating their sleep apnea. We're looking at using some medications to help sleep apnea CPAP compliance because only about 40% of people that get a CPAP actually use it. So it's a hard problem to solve. We have one study where we're looking at orofacial muscular therapy. It has been shown, it's big in Brazil, but and Europe, that can reduce your sleep apnea events. So there are a number of sort of approaches that I think need to be done in concert. I think it's something that you can't overlook.
Well, I want to be mindful of time. It is top of the hour, but please join me in thanking the commander for his talk today. Thanks.
Not